Hi and good morning, everyone. I'm Associate Professor Dr. Rosiani Muhammad from UNC Science Malaysia. Would like to share with you about female sexual dysfunction, the Malaysian scenario. In Malaysia, FSD is prevalent but often underreported due to stigma and cultural sensitivity. This causes limited open discussion among doctors and patients, hinder awareness, and sometimes they have difficulty to get help from us. Cultural norms, religious values, and also societal expectation further complicated this problem, and also for them to get the management or treatment from the clinics. So today I would like to share with you a review expose female sexual dysfunction prevalence, contributing factors to challenges that we face, followed by the current efforts to address these issues. So when we go through the prevalence in FSD in Malaysia, in general population, it's about 1 in 3 women actually having this problem, and the prevalence increase when they after they get pregnant or after they get delivered. So in postpartum period, usually it increase about 1 in 2 women. However, for those on contraceptive users, is about 1 in 10, and when they get older, for example, those already menopause on hormonal therapy, it can goes up to 85%, and also for those more than 60%, it also higher around 70%. So how about those who have chronic diseases? So we can see overall, all the prevalence is around general population is around 20%. But for those who have breast cancer or breast cancer survivors or gynecological cancer survivors, the prevalence is really high, more than 60%. And for breast cancer, can goes up to 90%. Okay, we also come up with the prevalence among healthcare providers for those who are in the tertiary hospital in Kuala Lumpur, meaning urban area. We just find about 5.5% having FSD. And the risk factors actually are related to longer marriage duration, reduced sexual activities, and also when their partner having a male sexual dysfunction, which is ED. How about and we have latest data. This one's still unpublished. Among primary care practitioners in Malaysia is around 14.7%, and the risk factors also slightly similar. Yeah, especially with the reduce in the sexual activity. And when I go through all the findings, we can categorize them into three factors that leads to FST. The first one is personal factors, mainly about age for those in middle and elderly, and those with chronic diseases, those with the psychological problem, and also for spouse, also about age. Okay, increased age can increase the risk, their performance, and also for those who have chronic diseases also can lead to this problem. Other than that, if they did SI less than 3 times per week, or they have a longer duration of marriage, so their risk factors even higher. So why is this method? So we try to go and did another study, which is a qualitative study, to understand more about female sexual dysfunction in Malaysia. So we go through their meanings of sexuality, and we find out that their meaning is very rigid. It's just confined to sexual activity, mainly sexual intercourse, about touching, about physical intimacy. And a little bit about they are talking about love, because Malays are is have a different, it's not romantic love, they have different types of love, which is responsible love. And also they are talking about responsibilities in marriage, about roles and right, okay, how to be a good wife, and they try to balance it with other responsibilities. And apart from that, they are also talking about procreation, meaning they want to get children because children are gift from God, and uh, there comes with the responsibility of to be a good mother as well. Okay, so when they get FSD, what's were the consequences? So we team up with three teams. The first one is they revise their own meanings. Okay, the meaning is still the same, but currently sex as obedience and not pleasure. So they perceive it something that they feel a very great loss. Okay, loss of hope, loss of pleasure, and also there is a change in terms of sense of love because they shift from the passionate love to compassionate love. Also reassess their own role as a good wife. They feel that they are not competent enough as a wife, and also this affected their motherhood, to be the way mothering. Okay, so they easily irritable, something like that. And the problems also affect their husband or their partner, causing the husband feel like rejected. Okay, and also sometimes we find out that they have a reciprocal dysfunction. The husband also later on get ED due to this problem. And other than that, they have a psychological impact as well, distress and relational conflicts, as mentioned here. Okay, so we come up with the model as mentioned earlier. This is the main thing is environmental factors that leads to the meaning of sexuality, and how these two, a male and woman, meaning husband and wife, with different values, different upbringing, comes together, and they have different type of behavior, skill, and knowledge about sex. Uh, Causing, if they can't tolerate each other, it can cause conflict and later on FSD. And all the consequences that I've told you before, and later on how they overcome the problem. So the clinical implication from this big study is actually we it's really important for us to have a comprehensive patient's history and assessment, address cultural and religious influences, and how we can empower women in their own treatment, meaning they have to do their homework, have to know the self-care about how to go about when they have this problem, and they need to have their goal setting, and we need to involve husband as well in the treatment. Okay, and lastly is about policy and education for the healthcare providers. So how about doctors, because we also interviewed the doctors how they manage FSD patients, and they come up with the barriers because they themselves feel taboo about this topic, because of they have limited knowledge and training, the unfamiliar with the FSD, as compared to male sexual health or male's sexual dysfunction like ED. They feel embarrassed by themselves and they try to avoid talking to patient, and sometimes due to unfavorable clinic environments, the clinic settings were not conducive to private discussion with the patient, and also sometimes the time is time's constraint. Okay. So these are the strategies that we are now using. So um, in the university hospitals, majority, and also big hospital like Hospital Kuala Lumpur or those thing, we have a team who work in this area. Okay, those who, especially psychiatrists, from the psychologist specialty, yeah. And we have a teamwork, we work together, and also we work with the partners from the Indonesia. We have a Psychiatrists Association of Malaysia who also joined us, and also we strengthen ties with Asia Oceania Federation for Sexuality, which I currently become a president, and I'm also involved in World Association for Sexuality, so for sexual health as a executive members, and some of us also involved in ISSM for global expertise. Okay, and we also produce books together for reference, either doctors and also patients. And now we offer female sexual health education in our curriculum, both undergraduate and postgraduate, and we also develop fellowship training for specialists, especially in primary care sectors. And other than that, we also establish our own clinic alongside with male sexual health because they come earlier than us, and we organize many webinars, workshops, and conferences for both professionals and public. Okay, with that, I think. Okay, thank you.